Good morning and good afternoon and good evening to those just now joining on the this webinar for Voice of Change, Elevating Stillbirths on the Health Agenda. We'll just wait a few moments for to allow people to join in. We're so glad that so many of you are able to come and join us all today. We'd love to know who's in the room, so please do enter your name and where you're from in the chat. It'd be lovely to hear who we have with us. Great. So I think people are still joining, but as they join, I just want to welcome. So my name's Hannah Blenko. I'm co-director of the March Centre here at the London School of Hygiene and Tropical Medicine. And on behalf of the March Centre, International Stillbirth Alliance and UCT Global Surgery, I'd like to welcome you all to this seminar webinar today. Just to note before we start that this is a sensitive topic and some of the things we discuss will be upsetting to some of you. Please, if you are triggered by any of the content, please do access resources here at Stillbirth Alliance, the web link here, and get in touch with us. But now I want to hand over to Paula Quigley, my colleague from International Stillbirth Alliance, to give an overview of the webinar and where we're leading from here. Thank you. Paula, over to you.
Thank you, Hannah, and welcome everybody. It's great to see people have joined and are interested. So I'm Paula Quigley. I'm the former chair of the International Stillbirth Alliance board, and I'm very happy to be moderating this webinar. So our objectives today, we are going to share the key findings from the State of Africa's Stillbirth report with you. And then we are going to highlight the priorities that came from two sessions that we held at the recent IMNHC, the International Maternal Newborn Health Conference. And we had two sessions about Voices for Change, and we're going to give you some feedback from that and some of the high-level recommendations that came out of that. And those are aimed to inform the Lancet Stillbirth series, which we'll be telling you more about. We are hoping to engage global partners and the voices of lived experience. And I'm sure there are plenty of you on this call, and we'd love to hear your voices, and especially any of you who weren't present in Nairobi at the IMNHC. So now's your opportunity to add some more voices to this process. We're really happy to hear from people. So in identifying some next steps. And then we want to discuss briefly about mobilizing collective action to elevate stillbirths within the maternal and newborn health agenda. And we have a wonderful panel here today to help us talk us through that. So on to the next slide, please. So this is the program, part one, the report, as I've just said. Part two is the consultation with Q&As afterwards. And part three is going to be an evidence to action panel with Q&A following that. So without further ado, let's go to the next slide. I would like to introduce Linda Vanuatu. Linda is a board member of the International Stillbirth Alliance for quite some years now. She comes from Ghana, and she is a parent representative. She has also established her own NGO in Ghana many years ago. And she's going to talk us through the key points of the State of Africa's Stillbirth report. Linda, over to you. Thank you. Next slide, please.
Thank you very much, Paula. Let me also add my voice to say thank you to everyone who has joined us today. We have this beautiful logo telling us about how important stillbirth is. Next slide, please. I'm doing this presentation on behalf of the whole team, the ISA, and we have this campaign which we started, it's been ongoing for some time, I Am ISA, where people share their reasons why they talk about stillbirth. And it's not just for parents, but it's for health workers as well, and for everyone interested in stillbirth. Now, the journey that we've been on has been a long one, and a very important one as well, because we're building a movement. And it started almost a year now. It's been quite long. April to June, as you can see on the board, we had the initial idea and the IMNHC abstract, which was submitted. And July to August, we had core partners convened talking about what should happen In September to December, we had the technical advisory group, which was convened and made inputs into the draft, which ended in the good report that we have. January to March, we had the report finalized, and we went to Kenya, by God's grace, and we took part in the conference. Now you can see here that we had so many people involved in this. African leadership, we had over 80 individuals, we had about 27 partner organizations, and we had more than 24 African countries joining. Next slide, please. Yeah, so this is the partnership and collaboration. It was a very important one, very great, and you can see so many people who joined just to show that stillbirth is important. Next slide, please. Now the report is set out very beautifully. So once you get it, you know what it covers. We have the burden, which talks about how big the problem is. We have the drivers. Why are these stillbirths happening? We have the impact as they happen. What does it mean? So why stillbirths matter? And then we have solutions. That's very important because there are things that work to prevent stillbirth. And then, of course, we have the pathways. How can the countries accelerate progress towards the reduction and prevention of stillbirth? Now, on the right, you can see that we have highlights of 10 countries. And 13 were collected, but we have 10 countries spotlight in the report. And we also have, importantly, 10 testimonials from families and health workers. This was very revealing, and as we go further into the discussion, I'm sure we'll hear more about that. Next slide, please. Now, stillbirths occur, but there are people behind the numbers. For every child that is born dead, there are people. And here you have some quotes, and they cut across. From South Africa, somebody said, there is no heartbeat. Returning home without a baby was devastating. In Tunisia, the pain remains like an open wound. And in Ghana, she said, I woke up expecting to hold my baby. Instead, there was silence. And we also realized that talking about it as a healthcare provider is not easy as well. So here you can see some quotes that breaking the news of a stillbirth never gets easier. And I believe that till something is done, this will not be easy for anyone to do. Next slide, please. Now, what is the burden? Almost 1 million stillbirths occurred in Africa in 2023. 2/3 of them in Western and Eastern Africa region. And there are 5 high burden countries, as you can see here. You can see the names right there: Nigeria, Ethiopia, Democratic Republic of Congo, Tanzania, and Sudan. This is important because as we move towards the action, we can know the countries that we need to focus on. And you can also see on the right here that these million stillbirths that occurred in 2023 did not just happen in 2023, but it's been on for 2 decades. From 2000 till now, the story has not changed. And this is why it's important. And Africa experiences nearly the same number of stillbirths today as in 2000. And 1 million affected women, and in fact, more than that, because the mothers, the fathers, the family, they are all affected. And that's why we need to talk about stillbirth. Next slide, please. Now, what is the burden like? If you look at the mortality transition framework, which is down here, and the graph is also showing the countries, you realize that most countries are in phase 2 and phase 3. And down there, you see what phase 2 and phase 3 refer to. And stillbirth rates vary across the continent. So as we look into the actions, this is also important. And from 7 to 34.9 per 1,000 total births. And this also shows that there are specific countries that need to be taken seriously as we look at addressing this. Now, for me, the graph is showing that we want to get to the final phase where we are looking at very low numbers of stillbirths. That is what everybody is looking for. And lower rates occur typically in Northern Africa and the highest rate in Central and Western African regions. Maybe there are lessons that we can learn from this. Next slide, please. Now, what are the drivers? Stillbirths happen, but they are not inevitable. And they persist because women and families face avoidable medical conditions, and nearly half of stillbirths occur during labor, reflecting the critical health system failure. However, it's not just the health system that fails. There are other things that drive stillbirths, and we can see from here that there are medical causes and risk factors, and on the right we have some idea of what that should be. There are social cultural barriers. There are determinants of health. There are the health service and data issues, as well as policy and structure. And under the policy and structure, for example, we have the governance, where we can have the targets, the financing, and women's rights. And so this slide is telling us that there are things that can be done if we want to prevent stillbirths. Next slide, please. Now, what are the data gaps? Data is a very important thing if we want to move forward. And this whole report was built on the data that was available. Now, on the right, you can see the legend. The lighter portion shows areas that do not have data. And there are more than those that had the data, albeit whether limited, medium, or high quality. And so this shows that most African countries do not provide quality data on stillbirth. And the challenges preventing accurate counting and causes of death classification are listed here. For example, there's a fragmentation across data systems. There's also the inconsistent definitions and limited digitization. And so these contribute to the data gaps that we have, which need to be addressed if you want to prevent stillbirths. Next slide, please. Now, stillbirth has a huge impact on the mother. There's a psychological and emotional distress. On the father and the family, again, they have emotional and psychological distress, as well as economic burden. And for the health workforce, it is absolutely important because they have moral injury and burnout. And for the health system, there's increased cost. There's also the inefficiencies in the use of the limited resources that are available. And on the society, there's lost productivity and human capital. So the impact of stillbirth is quite huge, and it cuts across this and many more. In fact, many more. Next slide, please. Solutions are there for us to follow. And if you look on the left, you see that the health system resilience, if you're able to build that, we will save mothers and children. We'll be able to prevent disabilities. We'll be able to support the family and build proper health systems. And of course, we'll prevent stillbirths because 70% of stillbirths are actually preventable. And on the right, you also see here some of the things that can be done within the community and also during the health service, the health system, at the health system level. We can address adolescent issues. We can address the issues to do with antenatal care, improving that. Intrapartum care, if you remember, most of the deaths were occurring intrapartum. And then, of course, if we have prenatal care as well, that if all these things go on together, we will be able to activate systems that will prevent stillbirth because we will diagnose things earlier and also provide bereavement care because all these will help. So these boxes right here tell us some of the things that we can do as solutions to prevent stillbirth and provide bereavement care. Next slide, please. Now, prioritizing access and effective coverage. This slide is showing us some of the gaps that exist with all these areas, be it demand for family planning, because if they don't become pregnant, of course, they will not have stillbirth, and whether they will be satisfied with the methods, the antenatal care service, the skilled delivery, the institutional deliveries, which is what we want. So if they are coming and the babies are dying, that is not good enough. So this is telling us that there is a lot that needs to be done. And postnatally, there's also the care for these women and the families that have this. On the top, again, we are introduced to the phases that we saw earlier. and the prioritized areas that we can look at for us to prevent stillbirth and provide proper care for the families after stillbirth. Next slide, please. Now, what we're talking about fits in very well. It's not on its own. It fits in very well with every woman, every newborn, everywhere, where they have seen that if these things that are listed here are done, 90% of every pregnant woman receives proper antenatal care at least 4 times. If we have every birth, at least 90% of every birth provided by a skilled birth attendant, and if we have 80% of every woman and every newborn receiving good postnatal care and essential newborn services, and if we have 80% availability of emergency care and social determinants of health are addressed, then of course we will be able to have good pregnancy experiences and outcomes, and we will reduce stillbirth and provide good bereavement care if the unfortunate happens. And policy and plans have to be good. There should be investments, there should be response, of course, the data, the health workforce, and commodities, as well as everything else that is needed, should be in place for us to prevent stillbirth. So it fits in very well with the every newborn, every woman, every newborn, everywhere agenda. Next slide, please. Ladies and gentlemen, the pathway, which is our call to action to 2030, there are many things that can be done. Commit and lead and invest. That's why we are happy we are here today, for us to be committed and to lead the movement. There's also the issue of building the capacity of the health system to deliver quality care. Data is key. So we have to count, not just count and put it down, but to use, learn from them, and then prioritize what can be done. And we should also provide centered family and community care. By empowering parents, we will raise awareness and they will also respond to whatever we want to offer. And then also the contextualized action by tailoring strategies to mortality phases like we saw, and the countries that need to improve on specific areas. Next slide, please. So within this short time, I've taken us through this huge report, and we hope that you will find time to read the report and know that we are trying to prevent this issue of every 30 seconds a baby is stillborn. As we have said from the beginning till now, many babies have been stillborn, and this is what we want to prevent. Thank you very much for your attention.
Thank you so much, Linda. You did a fantastic job on getting us through a big report in a very brief time. So apologies if this is a lot of information for you, but I think some of you are already familiar a little bit with the content. And the report is available online, and several sources will be sharing all that with you. I'm going to move straight on to the second presentation, and then we will break for some Q&A. Please do put your questions as you think of them into the Q&A, and we'll be monitoring that, and we'll pick those up after Aliki has presented. So I would like to introduce Aliki Christou. Aliki is a research consultant with the Stillbirth Centre of Research Excellence in Australia, and she's a research fellow at the Institute of Tropical Medicine in Belgium. And Aliki was also involved in helping to develop the report, but also in helping to facilitate the sessions at the conference. And Aliki is now going to present the findings to you. Aliki is also one of the core authors on the first paper in the Lancet series, it's upcoming, on looking at what has happened since the last series was published in 2016, and what are the gaps still to address. So Aliki, please, over to you. Thank you.
Thank you, Paula, and welcome everyone. Thank you so much for joining today. Next slide, please. Okay, so I will be presenting a summary of 2 consultations that we had at the IMNHC conference. Next slide. Okay, so this consultation aimed to bring together a wide range of stakeholders to identify priorities and actions for stillbirth prevention and integration into health agendas. At the center of this consultation was one key question that we wanted to ask, and that was, what are the most critical gaps and actions needed to improve stillbirth prevention and prioritization over the next 5 years and also post-2030? So these findings were intended to inform the State of Stillbirths in Africa report and also the forthcoming Lancet Stillbirth series. If you could just click on the next slide, please. So stakeholders were asked to identify the top challenges, research gaps, priority actions, and the role of parent voice across 4 critical themes. So this was political prioritization and integration, sociocultural beliefs and practices and communication, solutions and innovations for prevention, and bereavement care and parent voice. There we go. So we had 2 consultation sessions during IMNHC. The first one was during the Voices to Change satellite session, and this was a 90-minute multi-stakeholder consultation with over 90 participants from 23 countries, including policymakers, clinicians, researchers, affected parents, NGOs, international organizations, and donors. And the second session was a participatory learning session involving around 40 parents and frontline health workers, and focusing on sharing their lived experiences and generating practical recommendations for research, policy, and program design. So next slide, please. So both sessions used facilitated group discussions using worksheets and flip charts, and where possible, we tried to include an affected parent as a co-facilitator for each table. The groups also had the opportunity to present and feedback their discussions to the plenary and to the wider group. Next slide. So here you can see some of the flip charts and documentation that we collected during these sessions. And we synthesized these findings using thematic synthesis and also some of the verbal feedback that we got during the session as well. And we organize this according to the 4 priority thematic topic areas, and I'll take you through that in the next slides. Next slide, please. Next slide. So next slide, please. Yeah, okay. So what we did, so for each theme, we've organized the findings according to the top challenges, research gaps, priority actions, and the role of parent voice that the stakeholders identified. So there's a lot of information on this slide. We had very rich discussions. So theme 1, political priorities and integration. The overarching message from these discussions was that stillbirth remains largely invisible within political agendas, data systems and development frameworks, and that financing and targets will be critical. So stakeholders also highlighted the lack of leadership and accountability that was holding back political prioritization and the lack of integration into MNH policies, and also the perceptions that stillbirths were not seen as a death that counts. Broader health system constraints were also highlighted as a key barrier. And some of the top research gaps included the need to learn what's worked in different countries through country case studies, what financing and policy models can support successful stillbirth integration, and also how sociocultural factors can prevent prioritization in different settings. And some of the priority actions that stakeholders highlighted here were centered on really securing explicit political commitment with financing attached and establishing stillbirth targets and action plans, and also improving integration and data systems, integration within data systems, policies, and delivery structures. And the role of parent voice that was highlighted here was as advocates and stakeholders in policy and research, and particularly helping to increase visibility and mobilizing parent-led associations. So next slide, please. So theme 2 on our sociocultural beliefs, practices, and communication. Here we found that stigma and silence really contribute to prevail and operate at every level. And this is really preventing action. And that communication strategies and how stillbirth is portrayed will be key to making change. So stillbirth continues to be viewed as a women's issue, and women are blamed for the outcomes and also prevention. Stigma persists at both community and facility level and impacts on care seeking and support. The lack of recognition of stillbirths as a human loss or as preventable was also hindering efforts. The top research gaps that stakeholders identified was a need to better understand what's happening in the community in terms of beliefs and care-seeking behaviours, what's happening in facility practices in terms of identification of stillbirth, and also what are the gaps in healthcare provider training. And the priority actions that were highlighted here included measuring and reducing stigma so we can normalize those discussions, and reframing stillbirth as a shared issue that is preventable, and also creating communication strategies and plans across the different levels. And in terms of parent voice, parent stories were highlighted as key in terms of being able to break silence and increase visibility at the community. And also parents can play a critical role in identifying unmet needs, and particularly around mental health and respectful care. Next slide, please. Okay, so theme 3 was on solutions and innovations for prevention. And here we found that really, I think everyone knows that evidence-based interventions exist, but are just not funded or scaled, implemented at scale. And access to essential supplies and resources, including fetal monitoring, ultrasound, and emergency obstetric care, is limited. Data and data systems and use of data to inform implementation are also insufficient. And stakeholders in these discussions identified that the top research gaps included, why known interventions are not used, and the need for implementation research, particularly in high burden settings, and a need to understand causal pathways and risk prediction. They also highlighted that integrating stillbirth, more research is needed in integrating stillbirth in tracking systems to inform decision making. In terms of priority actions, here the key actions were focusing on scaling and funding interventions, strengthening healthcare provider capacity, and improving data use for action and accountability. And the role of parent voice in this theme was seen as critical in identifying quality of care gaps, being involved as co-designers in services, and building trust between communities and the health system. Next slide, please. Okay, so our final theme was theme 4, so that was on bereavement care, mental health, and parent voice. And the key challenges in this thematic topic were around that bereavement care is really inhibited by cultural norms, and this really prevents open discussion, and that bereavement care is really not prioritized within health systems. There's no dedicated space or training, and counseling and psychosocial support is not provided after stillbirth. So parents continue to also be blamed, silenced, and not acknowledged within health systems. Some of the research gaps highlighted here were understanding what interventions actually work and how they respond to parent needs, exploring more around parents' experiences of care and communication, and looking at healthcare provider capacity and health system readiness. And some of the priority actions under this theme included integrating bereavement care into standards of care, integrating parent voice, training providers in perinatal grief, so including that within pre and in-service training, and really learning from existing good practices. And also raising awareness to create demand for respectful care. So the role of parent voice here was seen as parents being advocates and champions to also improve accountability and learning by embedding their voices in systems through feedback mechanisms in audit. Next slide, please. Okay, so the second session, second consultation session was a participatory learning session. So this, as I said, brought together parents and frontline workers to share their experiences of baby loss and to advocate for more respectful care. So the session provided a platform for dynamic exchange between parents and healthcare providers, and also for future engagement. And participants were encouraged to really share their stories and learnings and challenges and potential solutions. And so these discussions we wanted to directly inform the 3 Lancet Stillbirth series papers. Next slide, please. Okay, so this table summarizes the findings from the sessions according to the 4 thematic topics. So you can see those in the left-hand side column, which we then mapped across the 3 Lancet Stillbirth series paper topics. And overall, the key themes were similar to what was raised during the first session. So I'm not going to go through this in detail, but just to highlight that, you can see the same sort of things coming up there: the lack of prioritization, the weak integration, framing as low priority, the limited investment, the need for communication to address stigma, that bereavement care is not embedded within policies or standards, and that families remain invisible to systems and also to communities. So next slide, please. Okay, so the learning session also focused on, what has improved in the last 10 years and some of the success stories. And we mapped this also according to the 3 thematic topics of the Lancet Stillbirth series papers. So under political priority, participants highlighted that overall their visibility is improving. We do have more awareness, more capture of stillbirth, more inclusion in national plans, and greater parent involvement. In bereavement care, there's definitely changes there. There's increased interest in bereavement care. Separate rooms for privacy are starting to be provided. There's more support groups and NGOs involved, and some initiatives to support healthcare providers. And under implementation, parents are increasingly engaged. The tools are expanding. There's more testing, more training, but still insufficient. So we can see there's clear progress. We've made progress over the last 10 years, but this is not happening at scale, and particularly in high burden settings. So there's still a lot of work to do. Okay, next slide. Okay, so based on the 2 sessions, the 2 consultation sessions, we've tried to synthesize some key priorities and actions going forward. So the first one is strengthening political commitment and accountability with financing and integration into policies. So that's also including setting those stillbirth targets and linking commitments to dedicated financing, and also integration into MNH policies and accountability platforms. Action 2 was around transforming data systems for action. So strengthening MPDSR, integration of stillbirth into civil registration and vital statistics and HMIS systems, and really using this data for real-time decision-making and accountability. Action 3 was scaling proven interventions for quality of care at birth and during pregnancy. So expanding access to antenatal care, fetal monitoring and emergency obstetric care, and addressing those workforce gaps to improve intrapartum care quality as well. Number 4 was addressing stigma and shifting social norms. So implementing communication strategies at all levels, reframing stillbirth as a health system issue and not an individual issue, and really engaging men, families, and communities. Number 5 was integrating respectful bereavement care, including with pre- and in-service training provided, and ensuring that we have psychosocial support for families and creating the space and protocols needed to provide that compassionate care. Number 6 was really centering parent voices in systems in systems and solutions with formal engagement and feedback mechanisms. So really supporting parent-led advocacy and peer networks, and embedding parent feedback into facility audits and accountability processes, and co-designing services with affected families. And number 7 was around shifting framing. So shifting the framing of stillbirth from low to higher priority, to emphasizing that it's not only a women's problem or responsibility, and that it's a preventable death and a human loss. So in addition to these, so these are all very stillbirth specific actions, we do need to ensure that, there is this whole system strengthening also taking place at the same time. So these key enabling factors that need to be there to ensure that systems and supplies and staff are ready and able to deliver. Okay, next slide. All right, so these findings and priorities are really just a starting point from this initial consultation that we've done. And we really want to ensure that they reflect the realities and needs and lived experiences across different settings and perspectives. So we're inviting you to give further input through this online stakeholder survey, and we ask you to share this amongst your network so we can get as much input as possible to help refine and shape these priorities. And so this survey includes the same questions that were asked during the in-person consultation. So we just want to expand this and get more input beyond just the in-person consultation at the conference. So yeah, we would greatly appreciate if you could share this and help us shape the next steps for research, policy and advocacy and action for stillbirth prevention and bereavement care. Thank you.
Thanks so much, Aliki. And just before we go to the panel discussion, we just want to give you, and apologies that the chat wasn't working for all participants at the start there. I see it's working now and people are introducing yourself. It's great to see so many people. That's absolutely wonderful. So please continue introducing yourself now that the chat is working. And yes, we'll put that survey link into the chat for everybody. So we're just going to pause for a few minutes to see if anyone has any questions about the reports and about the consultations that took place in Nairobi. So we'll just pause for a minute. And Hannah, I don't know if you've picked up anything yet in the Q&A or the chat.
Not yet. So please do put your questions in the Q&A if you have any questions, and Karen, introducing yourselves in the chat.
Right. And Hannah, are people able to, can we unmute anybody if they want, if they do have a question?
We're just working on that at the moment. I'm not
You're
sure we're going to be able
to,
but I think it's what we prefer is to hear from everyone. So please do put your questions in the Q&A, and then our panelists and members will be able to answer them.
Perfect. Okay, well, if there are no questions for the moment, let's head into the panel discussion, because we'll pause again after that for questions. So if we just go to the next slide. And with great pleasure, I introduce our wonderful panelists. So we have a lovely group of people who have been all highly engaged in the writing of the State of Africa Stillbirth report. So Emily Atuhere is a public health specialist at Africa CDC. She's working on mortality surveillance and data systems, and she brings a continental data and accountability lens to us today. Adenyi Aderoba is the Regional Advisor for Maternal and Perinatal Health at WHO Regional Office for Africa, and he brings the regional perspective on policy and health systems implementation to us today. Then we have Vivian Geico, who is a parent advocate and a member of the International Stillbirth Alliance. She also is a founder of an NGO called Empower Mama in Kenya, and she brings a civil society and advocacy lens to us today. Gagan Gupta is extremely well known, I'm sure, to all of you. Gagan's a senior advisor with the Maternal and Newborn Health at UNICEF in Nairobi, and brings expertise, of course, in global monitoring, newborn policy, scaling quality care. Mary Kinney is a health policy and systems researcher at the University of Cape Town and was absolutely a key driver in getting the report finalised. And she brings a research policy and implementation lens to focused on stillbirth prevention and accountability. And last, but by absolutely no means least, we have Rajat Khosla, who's the Executive Director of PMNCH and brings, of course, that partnership and advocacy and global accountability perspective for women and children's health across and adolescent. So we're asking two questions of each of you, and it's the same question to all of you. And it's, what are you or your organization planning to do to take forward the State of Africa's Stillbirth call to action? And secondly, how can we leverage the Lancet Stillbirth series as an opportunity to advance this agenda? So if you'd all like to put your cameras on, please. And I would love to invite Vivian to, I think everyone has their cameras on. Great. Vivian, would you like to speak first and tell us your perspective as a parent and a civil society advocate and everything else that you do?
Thank you very much, Paula. It's such a delight to be in this panel today. As a lived experience advocate in stillbirth and infant loss, working at the intersection of peer support and community engagement, the personal experience of a loss and supporting other families has just shown us how stillbirth is not just an individual tragedy or a medical issue. It's actually a systems failure. It's a failure in accountability and response. And until we treat it that way, we'll still continue underestimating the impact and the urgency for change. So I'm really excited about this conversation today. And Linda told us about the new statistics there that every 30 seconds a baby is stillborn somewhere in Africa. And for me and for us at Empower Mama as an organization, even for the International Stillbirth Alliance, these are not just numbers. These are faces. These are people. These are mothers. For me, I see a mother just sitting quietly in a maternity ward after everyone else has gone home with a baby. I see fathers who are trying to stay strong while they're still carrying confusion and grief that they were never taught how to express. I see healthcare workers who are overwhelmed, trying their best in this kind of system. And personally for me and many of us who are doing the advocacy work, advocacy was very personal before it became professional. And as an organization, we want to take this report forward. There was the pathway call to action to 2030, and one of that is keeping families at the center. And we'll just continue to break the silence about stillbirths. And how we do that is just by creating spaces where parents can speak honestly about loss without, feeling shame, because in many communities, parents are suffering quietly because pregnancy and infant loss, stillbirth included, it's surrounded by stigma and shame and blame. And some mothers are even told not to talk about the baby. Fathers sometimes hide their grief. And we want to continue creating safer spaces for those conversations. Because when parents are given permission to talk, sometimes mothers even share stories of for the first time many years later, and then they would say, oh, I actually thought I was the only one. But that human connection really matters, and also really matters in bringing change. Secondly, it's not just awareness, but, we'll continue pushing the conversation beyond the awareness and into accountability, because families actually, they're the ones who see these system failures in very real ways. A mother might describe, waiting for hours before being referred, or a father can even give a story or explain how they struggled to find transport when during an emergency at night when he wanted to take the mother to the hospital to deliver. Parents also have talked about being discharged from hospital without emotional support or explanation. And these stories are not isolated experiences. And I'm glad that the Status of Stillbirths in Africa report captures that from different parts of the continent. And this collectively just show us that it's actually gaps within the system. So we'll continue pushing beyond the awareness and into accountability. And lastly, it's about respectful care after loss. That is what we'll continue doing, because families don't forget how they were treated on the worst day of their lives. I know sometimes healthcare workers are also overstretched and unsupported themselves, but compassionate care really matters very deeply. So very simple actions like acknowledging the baby, allowing the mother and the family time to grieve, and providing information on what happened and emotional support is something that is very helpful to families as well. So sometimes what stays with them forever is not the loss itself, but the words that were spoken afterwards, or the silence, which has been loud in this space. So those are the three things we plan to do as an organization. Thank you, Paula.
Thank you, Vivian. Thank you so much. And it's just so important to put the parent's voice at the center of everything we do and all the actions that we want to take. And that is our absolute aim in this Lancet Stillbirth series, is to make sure that that parent voice is ringing loud and clear throughout all the papers. Even though the third paper is more focused on bereavement care and support, we want to have that parent voice absolutely integrated throughout. So important. Lived experience is how we should be, framing all of our actions, starting from the lived experience and listening to those people, what they want, what they need, and how we can all best support that. Thank you so much, Vivian. You're a wonderful parent advocate and a wonderful resource for Kenya and Empower Mama. I would like to pass to Adeni. And Adeni, as the regional specialist in WHO Africa, tell us what WHO Africa is going to do to take forward these actions and how we can link that up with the Lancet series. Thank you, Adeni.
Thank you so much, Paula. And let me also start by thanking Vivian for the insights that she shared. I think the issue of bereavement, like you said, it's very important for the WHO as the UN agency that is responsible for health. I must say that the issue of stillbirth prevention, it's very integral to WHO's mandate of health for all. And when we look at what we do, a lot of advantage in moving in the area of health, it's around and the issue of the convening power to bring people together for important actions, particularly in this case for stillbirth prevention, the normative authority that the organization has, the fact that across all countries in the African region, we are able to leverage our country offices at both national and subnational level. I must say that for any action to move, the framing, as in the call to action around policy, it's very important. And using that convening role that it has at global and regional level, WHO has been able to use the opportunity of the World Health Assembly, the Regional Committee of Member States, to really move for different actions and resolutions. And at this point, it's about moving from those resolutions to what happens at country level. And we do have this policy support and framing being supported across different countries. A good example is what happens in Namibia, where you now have a national act that helps to review maternal newborn death, but it has within that framework very visible the issue of stillbirth prevention. And in many of these policy framing moving forward, it's not just about having some of these policies or laws. It's also about the mechanism to ensure that actions can take place. One of the ways in which we also galvanize action and which will be strengthening going forward is the IWINI platform. That is the Every Woman, Every Newborn, Everywhere, which is a framework to bring partners together across different domains for action, whether it is the issue of financing, health workforce, strengthening different areas of the health system. These are very important things that we are doing. And going forward, an important thing that needs to be done that WHO has been doing and will continue to do is to support countries to institutionalize stillbirth as a core health system performance indicator, such that we are able to move it from a hidden silent subtopic to a very important indicator of system quality and preparedness, such that countries are able to report routinely. We're able to support them to have scorecards that show the issue of stillbirths very visibly, and also such that we have their health sector strategic plans visibly showing the issues that has to do with stillbirth, such that we can position stillbirth as an important health security signal. I also made mention of IMNHC and closely linked to that to help some of this framing and improving quality of care at country levels is the explicit thing that needs to be done in supporting countries about their stillbirth reduction targets, not just at national levels, but how they can fully integrate this to have some of these targets also at subnational levels and use different mechanisms available to them, such as maternal and perinatal death surveillance and response, not just for maternal and newborn deaths only, but also for stillbirth, to really ensure that every stillbirth matters, every stillbirth, we get the learning and the actions that are important for this, and also ensure that some of the things that has to be done with regards to recommendations for this are not just narrative reports, but support countries to be able to make policy change around issues of staffing, commodities, quality of care, and referral frameworks that can help to improve action. A key issue, which I've also said before, is how do we improve quality of care? Earlier presenters have made mention of the fact that ultimately, majority of the stillbirths are issues that happen during facility-based care, such that we do have tools, but how do we ensure that these tools are deployed at scale? And one of those is the WHO Labor Care Guide, which is a quality standard that helps countries to organize care around how do we support continuous intrapartum monitoring, how do we bring women and their families into decisions and interventions during the time of birth. How also can we ensure that countries are supported to have round-the-clock functionality for emergency obstetric and newborn care, which bereavement care has been flagged within some of these things. So I think these are some of the important areas that we need to strengthen going forward, and which WHO will be speaking to and continue to support. A critical issue also is how do we ensure we have data for action. At present, the issue of stillbirth, it's relatively invisible in routine data system, routine surveillance, as well as vital statistics at a country level. So it's important for us to be able to support countries to deploy some of and improve some of these areas, such that also organize them to learn from one another. We do have, for instance, in Nigeria, the National Stillbirth Dashboards that is helping action. In Burkina Faso, the weekly stillbirth surveillance systems. These are some of the learnings that WHO has supported and can be used across different areas across the region. Coming to the issue of the Lancet series that is going to come out soon, I think it's really an important opportunity to help position the issue of stillbirth and use the Lancet not just as another evidence, but an opportunity to gather political capital, to gather funding, to further unlock high-level commitment globally, and not just having it as a global action, but also ensure that Africa is clearly shaping some of the issues that will be featuring in this Lancet series. So it's an opportunity, and I think the consultations, as we have them, it's showing some of the voices that are coming up from the region, as has been seen in the consultations in Nairobi. Beyond some of these conversations, to how do we ensure that the Lancet series is also leveraging additional voices through different platforms in Africa, such as the regional committee ministerial platforms, the African Union presidential platforms, to ensure the evidence that we have feed into some of these places to justify commitments, reforms that needs to take place around health workforce, financing, availability of essential medicines, strengthening systems in country. And these are some of the areas that WHO will be working on going forward.
Thank you so much, Adeni. And it's so great to hear about the action that WHO is going to take. And of course, as the world-renowned authority on health, this is a hugely important channel for action to happen and supporting countries to enable that action to happen. So thank you so much. And of course, as one of the co-chairs of the Lancet Stillbirth Series Advisory Committee, you're going to be in a prime position to drive that through and for us all to be supporting that and promoting that. So thank you so much, Adeni. Emily, I would love to move to you and hear about your perspective from the Africa CDC. And we were so sorry that you were unable to join us in Nairobi in the end, but many of your colleagues did. And, we're very active participants in these consultations and the satellite session. So please, over to you, Emily, to tell us a little bit from the Africa CDC perspective. Thank you.
Yes, thank you very much, Paula, for this opportunity. Good morning, good afternoon, good evening, everyone on the call. It's my pleasure to be here on this webinar and most importantly to, listen to the different voices, that have been behind the scenes trying to really amplify the message, the agenda for raising stillbirths on the top of the global health agenda. I believe not only for the African continent, but for the global health as well. So for Africa CDC, I believe that this is, in a way, a defining moment. Looking at the launch of the State of Africa's Stillbirths report, that has positioned stillbirths at the center of the health security agenda for the African continent. There is a lot that we need to step back and ponder at and ask ourselves some questions. Stillbirth is not like a new phenomenon that has just appeared recently. It's something that has continued to happen to take away precious lives just before they begin counting their first day, on Earth. And for us at Africa CDC, this is more of a silent epidemic that has continued to plague our continent for so many generations with limited interventions, I believe, because stillbirth itself is not an impossibility. A big proportion of the stillbirths that we have seen, especially in the presentation of the report, are actually preventable occurrences. These are babies that would have, with the right interventions, timely interventions, would have lived and fulfilled destinies and contributed to the development of the continent at large. So what does this report then mean for us as Africa CDC? Now is the time to get to work, because this report presents us with solid context-specific evidence that we need to look at critically and ask the critical questions. What is it that we have not done? What is it that we have done differently that we need to do differently? What is it that we need to change so we can be able to improve the outcomes, turn the pages from stillbirths to live babies, to lives that actually have been nurtured and grown to contribute to the key areas of development in the continent. So first of all, looking from the health security perspective, it is important for us as a continent, and this is where Africa CDC starts, sees everything from this perspective. If we talk of health security for the continent, it means that health security must begin from pregnancy to birth, and then we continue through the lifeline of a person. So if we continue to lose babies before they are born, then it means that we are not in charge of our health security, and we need to do more to ensure that we have more positive outcomes from the time of birth and all the way through life. We continue to intervene appropriately depending on the different health security issues that do affect our population across the continent. And for us to be able to do this, this report presents us with a challenge of walking the talk. It is now time that we need to begin to look at how do we move beyond the advocacy platforms, beyond the good speeches, beyond the meeting room, boardroom discussions, to delivering services that can actually promote life from pregnancy through childbirth and all the way through the life course. And so for us, stillbirth comes as a very strong and sensitive indicator of how well our health systems are functioning. And with this, we also see an opportunity that we can leverage as a continent, as partners, as global and regional partners and implementers to come together and have a coordinated approach towards actions that can prevent stillbirths. The publication of this report is a clear example of how much we can do together if we can collectively come together, coordinate ourselves, have coordinated interventions and actions, coordinate resources that are, invested in different intervention packages or different countries or different regions. It is important that we begin to look at how do we have a proper roadmap towards a coordinated approach for improving stillbirths in the continent. You can see that on this call, we have a cross-section of different players, from the policy makers to the national actors, to the academia, the researchers, the groups, and all of us are coming together to have one voice to say stillbirths needs to be addressed at a level that is sufficient to improve outcomes at the grassroots. And for us to do this, yes, we have to come down from statements of advocacy to begin to think of how do I member states to have implementation plans that can actually deliver, of course, not leaving behind the coordinated approach. Next, we need to think about our systems. What is it that continues to facilitate this poor outcome that I believe at the core of everyone we would love to change? I think it is important, and from an Africa CDC perspective, it is important that we begin to look back at our health systems in light of strengthening the health security of the continent, of our mothers and the babies and everyone in the community. What is it that we need to strengthen at primary health care level that is important and will help us to improve outcomes when it comes to improving stillbirths and, of course, maternal and perinatal outcomes? And so with this, we believe that stillbirth cannot be achieved through standalone programs. It requires stronger primary healthcare interventions that are integrated with functional referral systems, resilient emergency care, all of which fully align with the Africa CDC health security and sovereignty agenda. Let me also mention that as Africa CDC, we do really have a mandate to support member states to strengthen data systems so that we can have quality data that informs timely decisions and actions at different levels. And so what does this mean in terms of stillbirths? We are looking at integrating stillbirths strongly as as part of our interventions for strengthening and improving data systems so that we can be able to count every baby, every stillbirth, but also not just for the sake of counting, be able to work with our member states to make sense of the data that they collect and ensure that this data is useful for decision-making and accountability purposes. We believe that this is Central Africa CDC's efforts, especially looking at the line of strengthening mortality surveillance systems, which we've been at for quite a bit for now. We are looking to see how we also center stillbirth at the in the agenda for strengthening mortality surveillance, so that we can be able to use this as a complementary source of public health data that can be used for both public health intelligence purposes, but also help at program level to inform evidence-based interventions. However, for us to be able to do this, we need to be able to look back at what are the enablers that need to be in place for us to be able to have a successful intervention and successful outcomes that will then contribute to the health security of our continent. We do know that we currently have practical, bottlenecks to implementation or service delivery when it comes to, maternal child health services. And this is not an area that we as Africa CDC have all the solutions to offer to ensure that we have a strong workforce that can be leveraged to offer services, especially for pregnancy and childbirth. However, like I said, if we are well coordinated, then we are able to leverage the different resources that each of us bring on board, our partners, member states, international development partners. We all can together begin to map out how do we improve the health workforce that is responsible to help us deliver positive outcomes, give services in their time, and be able to save mothers and babies as we would like to see that happen. So we currently have a primary health care program that is very active around the continent. And we believe that through the interventions of a primary health care center, we will be working closely with so many of you here and our member states as well to begin to tease out what are those priorities that should be happening and how do we position stillbirths in the broader agenda of improving maternal child health, especially knowing that this is an agenda that has been elevated to the level of our continental leaders at the AU summit, where the presidents committed to supporting interventions that improve maternal child health. So we continue to look at each of us with the expectation that together we will want to coordinate and collaborate our efforts and interventions so we can be able to support our member states to improve these outcomes. Lastly, in terms of the Lancet series, allow me to just mention that we are looking at this as an advocacy platform that will help to amplify this message to all the different audiences, both within the region and globally, so that we can be able to have a common message, a common understanding that will help us to implement the vision that we have for improving stillbirths on the continent. I will stop here and thank you very much.
Thank you, Emily. And it's wonderful that the Africa CDC is so engaged in this process and real leaders on the continent. We look forward to seeing how you work together with WHO, UNICEF and all the partners to make these all a reality as we write up the Lancet Stillbirth series so that we go into it with very powerful messages. I'm going to quickly move on. We have 3 more speakers, so I will ask you all to be relatively brief so that we can have a few minutes for questions and answers. I'm going to come to Gagan our dear friend is based in Nairobi now and with UNICEF. Gagan, please tell us what the UNICEF perspective is, how you're going to drive this action. Thank you.
Great. Thanks. Thank you so much, Paula. And also to acknowledge the leadership of Mary, Hannah, and Lucia on the Stillbirth agenda for now several years. And not to forget colleagues in the audience, Joy, who has been a great champion of the Stillbirth over years. And also acknowledging the presence of Africa CDC and Rajat from PMNCH and my fellow colleagues from WHO. Now, one thing we have seen in this year's even CSA report tracking is that after a decade, the needle has slowly started to move on stillbirth. There is a small change, but we are seeing a change after 10 years of stagnation. And just to mention a few things where change has started to happen, more countries have now reported to include stillbirth in the MPDSR. More countries have now reported to have stillbirth in the routine health information system. More countries have started to say that the ANC4 coverage to ANC8 transition, which will be an important driver if done with quality for the stillbirth. More countries have moved from the policy of ANC4 to ANC8. More countries have moved for having a birth companion in labor room, which can also influence the respectful care as well as the quality of care. And as Adeni mentioned on labor care guide, also more countries are reporting to adapt it. Also, more countries now have a policy for stillbirth registration as compared to what we have been seeing over the last 10 years. So definitely there is a good news which is happening, and a lot of kudos to all of you for all the hard work. Now coming to the second component in terms of the specific UNICEF support. So we would continue to lead the process of the even CSA progress tracking, which has now nearly more than a 10-year-old process where initially Mary and other colleagues like Joy and all were very much involved when it started. And progressively people have continued that. We have strong data from that 10-year timeline, and we're adding new data points every time. And this time on request of the Lancet group, we added a few specific data points. One was on the policy for bereavement care. One was on policy for maternity and paternity leave after a stillbirth and neonatal death. And one was on the parents support group. And on all these three indicators, the progress is very low. Just 10 to 12% countries did report that they have done something. And that would be captured in the Lancet series because that was specifically put on the request of this group. Now, in terms of more areas where we feel that, and not only UNICEF, even WHO and UNFPA colleagues, because we work very closely, mainstreaming stillbirth agenda into the even umbrella will be the key. Because the three of the targets, antenatal care, skill attendance at birth, and emergency obstetric care, all three of them would help to reduce the stillbirth burden. And we are now working on the quality of care indicators, where simple things during ANC for quality of care, during the skill attendance at birth and emergency obstetric care, if we are able to add those things, which will really help. A couple of more things which are not getting that much attention is the birth preparedness planning and the transport system for pregnant women, because sometimes it's not only about quality, but it is also about timely access and delays in the care. And last but not the least, I think what is important is, as even we have been following progress with a set of countries who have been engaged in the IMNHC conference. So we had a country engagement day on the last day of the conference where we had 36 countries who came together. And over the next couple of years, countries have identified their priorities. Many of them have also identified stillbirth as a priority, but many of them have identified other levers which will reduce the stillbirth. And as EVNE, between the three agencies, we remain committed to support these country acceleration plans and country priorities over the next period till the build up to the next conference. With this, back to you, Paula. Thank you.
Thanks so much, Gagan. Very, very concise, but very positive, and framing that we are making progress. We need to make a lot more, but we are making progress. And I think once you get on that trajectory of making progress, it can only get better and better. That is our hope and our aim. And more than that, that's what we really plan to achieve now. And these forces coming together hopefully are going to help us achieve all that. Mary, over to you. Mary must be rather still exhausted from having coordinated the the writing of the report and being in Kenya and now still doing all the follow-up and dissemination. Mary, over to you and let us know what your perspectives are. Thank you.
Thanks, Paula, and greetings to everyone. I'm asked to speak on behalf of academia and specifically UCT Global Surgery. And, for me, one of the biggest takeaways of the State of Africa Stillbirths report was the importance of how critical partnerships are to accelerating progress. This thing just doesn't happen, right? It happens through a carefully coordinated and planned work plan strategy and a lot of engagement and a lot of meetings. So I just want to say thank you to so many of you for being engaged throughout the process. And obviously we're continuing in that engagement with the Stillbirth series and the consultation effort that Aliki presented. And UCT wouldn't be able to do this without those partnerships, such as an MOU with Africa CDC, a partnership agreement with UNICEF. We had a small funding from Laerdal Foundation, which we were grateful for, but also being able to capitalize on these existing networks, such as IWENI or the International Stillbirth Alliance. So it was a huge effort, but I think what also came out of it wasn't just a report. It's a network that's growing. So we had over 80 people involved in the report from across 20 countries. I think it was 23 countries in Africa. And as UCT, we want to see how we can build into this network, for maybe a platform or leverage the Stillbirth Advocacy Working Group in Africa to enable some sort of implementation learning or peer learning or accountability. And that's what we heard from our technical advisory group when we had a kind of a reflection meeting a couple weeks ago. So I think from UCT, what are we planning to do next, beyond perhaps engaging in that type of platform in the network? As we know that the Stillbirth report was advocacy focused, but it was really, and it brought visibility and mobilization and some political attention. But behind that report was a huge body of work, analysis, evidence synthesis, country learning. And so our kind of initial text is to make sure that that's going to be published academically and further disseminated. So stay tuned for more information there. And also on the research side, we're continuing to engage in strengthening stillbirth data systems and accountability mechanisms. And that's where this work is really rooted with our partnership agreement with UNICEF and the work with Africa CDC. But I'm also, we're working with the NIHR OptiMap project, which is doing work in Uganda, Ghana, and Ethiopia to strengthen implementation of MPDSR. And I see some colleagues from OptiMap here. Thanks for joining. Our trial is about to start. And so really great progress that's happening on those fronts to strengthen data systems. And even here in South Africa, wanting to do more with our National Department of Health to strengthen the perinatal problem identification program and other accountability mechanisms. So we're open to collaborating more in that space. And I think IWENI and countries really have an opportunity to take the data that Gagan was sharing and say, well, which countries don't have a target yet? So I think a third of countries in the African Union that completed the survey that we did with them, only a third have a target, a national target for stillbirth prevention. And so maybe identifying which of the countries that we have actors and stakeholders and really do intentional advocacy, perhaps as part of the stillbirth advocacy agenda, to really work with governments and affected parent groups and professional associations to get a target in the next strategic plan. And I think, we don't see stillbirth as a vertical program at all, and it's fundamental to strengthening health systems. And for me, it's also about the access to safe surgery. So as Global Surgery, we will be doing more research on implementation for health system strengthening as well overall. And I think for the second question on the Lancet Stillbirth series that's forthcoming it's obviously a major strategic opportunity, and I know in a couple of ways. So first, we have an opportunity. I'm helping to co-lead the first paper, which is looking back to look forward. We are doing a political economy analysis to really understand what's changed in this past decade, why and why not, and what do we need to be doing differently. So we don't want to have the same call to action. We need to really look at what we hear in terms of the political economy analysis, and that consultation is part of the data inputs for that. But we'll be doing more research around understanding the political, financing, governance, sociocultural factors that influence political prioritization of stillbirths. And I think as a core team from the 2016 Lancet series, a few of us have been meeting for a few years now to discuss a new series. And we knew we couldn't do the same thing. And we knew we needed a different approach. And as the African proverb says, if you want to go fast, go alone. If you want to go far, go together. And going together takes more time, more coordination, more strategic planning. But it's given us this opportunity, and I'm so grateful to the Lancet for allowing us to do another series, but also to that core planning team, be really patient to set up, an advisory committee to really ensure that we're embedding, particularly African leadership and evidence into each of the papers as well, and affected parent voices. Half of the burden globally is taking place in Africa. And so we've been really intentional. Even the State of Africa Stillbirths report, which was African-led, grounded in lived realities of parents and health workers in Africa, we want to make sure that the Lancet series responds to it and builds momentum for action. And we need this series to go beyond admiring the problem, to have really practical actions that have been informed by our data for the next 5 years. And we need it to show that stillbirths is not a niche issue, but rather a core indicator of health system performance, which others have said already. And I think that, together we can do this, because we're not there yet in terms of stillbirths continuously being integrated into the burden, into investment cases. And it's not just for women and children specifically, it's actually more broadly for health. Because when we neglect to include that burden, we fail to represent the full burden on women, families, and societies that the impact of stillbirths has. So I think integration is going to be our really key message as we're going to move forward. Really, thank you very much.
Thank you so much, Mary. Yes, absolutely. So integration and partnership. And we are all showing a great demonstration of partnership here today, but we also need to go beyond our immediate network and bring in others into a wider net of partnership. And no better person to finish up our panel discussion on that than Rajat, the Executive Director of PMNCH, all about partnership and advocacy for better health for mothers and babies. Rajat, over to you for your last words. Thank you so much.
Thank you for that, Paula. And it's so fascinating coming at the end of such remarkable speakers and their presentations, and much to reflect on what already has been said. And I do have to say, maybe adding a couple of additional dimensions, including from the work from the partnerships perspective. We are meeting in a very unprecedented and challenging context where it is not just defined by the kind of the geopolitical tensions that we are facing, the funding cuts that have been experienced, especially by partners working and present on this call, but also a significant shift that we are starting to see in terms of the deprioritization of agenda when it pertains to maternal newborn child stillbirth related issues. And this is significant because it does impact what we are talking about. And as both Mary and Gagan in their presentations just now were saying, how do we shift the needle and take it from these just identification or admiration of the problem to what do we need to do about it? And what do we need to do about it is becoming extremely difficult in the present circumstances. And I really therefore applaud the work that is being done, the work of the Alliance and all the partners available on this call. Stillbirths, as many have said, is a litmus test for the strength and quality of health system. And indeed, if we fail to count these preventable deaths, we fail one of the most fundamental tests of the health system performance. And what we are trying to do through the work of the partnership is to commit to ensuring that every life and every loss is counted, acknowledged, and prioritized. So what is it that we are trying to do? And by I refer to the collective we present on this call and beyond. The first is for advocating for essential package of services that recognizes stillbirth prevention as a core health priority and not just an optional add-on. And we are seeing a lot of cherry picking happening. And as prioritization in global health takes hold, unfortunately, not many are picking these as their core priorities. And therefore, by integrating quality of maternal newborn care into national universal health coverage frameworks, we do aim to ensure that stillbirth prevention becomes a non-negotiable indicator for health system performance. The second is through a country work. The partnership works with local partners across 10 countries that we are active in across Africa, and these platforms bring together civil society, health workers, and governments to identify and address local gaps, including stillbirth prevention, surveillance systems, and bereavement care. And we continue and hopefully able to support our partners in country to do this work as they move along. The third part is the notion of accountability, something which we haven't really talked about in as much detail during the conversation over the last 90 minutes. And I hope we can, as we move forward through these indicators and surveillance tools that we've been talked about, but also demanding real change through the policy processes at the country level. And so in our work, we are making strong emphasis on human rights-based accountability as the way forward. This means holding stakeholders accountable, not only for reducing deaths, but also for ensuring dignity, respect, and quality of care. A couple of final points as I move to the second question, and much has been said on that already, is also making sure that improving the quality of care is a central priority for the partnerships work, including for the prevention of stillbirth and avoidable maternal and newborn death. And this includes promoting respectful and compassionate care through a rights-based approach to sexually reproductive health and rights, while ensuring that every facility can provide evidence-based emergency obstetric and newborn care. And then finally, I think I do have to emphasize achieving all of this requires sustained investments in education and continuous professional development of healthcare professionals, including midwives and community health workers, all of which is severely starved of resources, and how we can collectively bring our voices to bear. And which brings me to the Lancet series. I really cannot say much more beyond what Mary has already said in the last few minutes. The bit that I wanted to say, it's fascinating that we have this space in the Lancet, the world's biggest and most reputed medical journal by several means. But that evidence only is useful if it changes policy. And what do we do in terms of bringing that evidence, that Lancet series, under the eyes and the noses of policymakers who can make a difference, and make sure that they are having a reflection on the undeniable burden of stillbirth that exerts on their societies itself. And so I hope, as we look at all the work through the series, and very proud to be one of the co-chairs myself, that we do focus on how we are going to take that evidence to policy, from policy to action. We'll stop there now. Paula, back to you.
Thank you so much, Rajat. Yes, so summarizing so nicely all the issues around advocacy, but also accountability and the importance of accountability. Absolutely. That is what we need to work towards, greater accountability to all those families, mothers, fathers, and the society, the communities, really, who are bearing the brunt of the burden of stillbirth. So, Hannah, do we have any questions, or would anyone like to ask a question? If so, I believe the unmute function is now working, and you can raise your hand, and we will be happy to hear your question in the last few minutes.
It is working, Paula. I think we've only got 2 minutes left.
Yeah. Are there any questions in the Q&A? No, not at the moment.
So I think it might be good to hand over to Jennifer now, I think, at this stage.
Okay, great. Okay, but you have the link, I hope, and we will be, with this webinar is being recorded, and so you will all be able to continue to engage with us in any way you see fit, and please reach out to any of us to do so. And I would just now like to give Jennifer Yorkovich, who took over as the chair of the ISA board from me early this year. And Jennifer's just going to say a few words on behalf of ISA. Thank you, Jennifer.
Thank you, Paula. Yes, quickly. Hi, everyone. Jennifer Yorkovich, the board chair for the International Stillbirth Alliance. What an amazing session, highlighting not only the problem, but also the breadth and depth of expertise that exists in our wider community to address it. On behalf of the International Stillbirth Alliance, I thank the organizers and presenters and participants for your time and effort today. ISA is a global organization with hundreds of members spanning expertise in clinical, research, and programmatic areas and lived experience. And its strength is really bringing together these individuals to optimize expertise so the whole is truly greater than the sum of its parts. And when I was scanning LinkedIn this morning, I saw a post for this webinar from Dr. Chigozie Nwalozi, and he commented that he's grateful for platforms that bring together researchers, advocates, clinicians, and communities to address overlooked health challenges affecting millions. And in that, he summed up the purpose of ISA. If you'd like more information about ISA, please visit us at stillbirthalliance.org. See what we do. Join us. You know how important partnerships are for this work. So you can join us in this work to prevent stillbirths, raise awareness, and support parents and health workers. Thank you. Hannah, over to you.
Thank you very much, Jennifer, and thank you to everyone who's attended today. It's been wonderful to have so many people online. Please do keep this conversation going. Please do join the conversation, join the consultation. We'd love to hear from you all, and thank you very much to all the speakers, to those who've been involved with South Africa Stillbirth and the Lancet series, and goodbye to everyone.